Okay, so let's talk about some gas transportation. So ventilation of the alveoli. Okay, so we've spoken about ventilation versus oxygenation, right? The ventilation is purely just the function of the nerves that stimulate uh, the respiratory muscles, which are the intercostal muscles in the diaphragm, and they expand the chest, leading to lung expansion and inhalation. Okay, so and once the muscles relax, the intercostals in the diaphragm, that is, uh, exhalation is a passive process as the lungs recoil. Okay, so really, all you need is an open airway to make sure that inspiration and expiration are occurring naturally. Okay, so what can impair ventilation? Well, what if you choke on a chunk of food, like a piece of chicken, and it doesn't go down your esophagus, but it goes into your trachea? Well, that's going to impair ventilation because you can't inhale air around it, and you can't exhale air around it. So something is going to have to be done in the next few minutes if um, if this patient is to survive. Okay, so either the Heimlich maneuver or something has to clear this chunk of chicken that has uh, become stuck in the trachea. So that's an example of impaired ventilation. Okay, so let's go through the impaired ventilation PowerPoint here. So a narrowed or compressed airway. Okay, well, what about a lung cancer that's growing in the trachea or a bronchial tube? Well, that's going to impair inhalation and exhalation because the airway, wherever the lung tumor is becoming more and more narrow as the tumor fills the lumen of the bronchial tube. Okay. How about asthma, which is bronchoconstriction of the very tiny bronchioles deep in the lung. So when you have an asthma attack, you get bronchial constriction. So the smooth muscle of these little bronchioles contract, and they cause very narrow bronchial tubes, and there's typically a lot of mucus associated with an asthma attack as well. So that would be an issue of impaired ventilation as well. Okay. What about decreased neuronal stimulation? So you need nerves that come from your brain to stimulate the intercostal muscles and the diaphragm. What if there's some interruption there? Let's use an example. If somebody happens to get 5 times the dose of morphine. So someone was going to get 5 milligrams of morphine, they got 25 milligrams of IV morphine. And that has suppressed the ventilation stimulation from the nervous system. It's suppressed neuronal stimulation, leading to decreased ventilation. And the same would happen with a large dose of an IV benzodiazepine. You can suppress neuronal stimulation because you're suppressing the brain, right? So when you suppress the brain, you suppress the nerves, and you can get respiratory depression. So opioids and benzodiazepines are two groups that we're really careful with when we give intravenously. We often put people on an O2 sat monitor, maybe a bit of supplemental oxygen, because we know that those two groups can suppress the nerves that are stimulating ventilation. Okay. What about if someone is morbidly obese? So they have a lot of fat around their chest wall. Well, that's going to impair ventilation. Those intercostal muscles and diaphragm have to expand the chest wall, but what's blocking them? A large amount of tissue, and that's going to make it difficult to ventilate. So obesity can lead to hypoventilation. What about ascites, which is a huge amount of fluid in your abdominal cavity, typically from cirrhosis, from liver failure? Well, your diaphragms can't really compress downwards anymore. So because of that, you're not going to be able to expand your lungs, and that's because of reduced ventilation from all the fluid that's in your abdomen. Okay, so think of ventilation as just the ability to get air from the outside world to the alveoli. And anything that makes that more difficult, whether it's something stuck in your trachea, or a very large chest wall from obesity, or a very protuberant abdomen from ascites or pregnancy, will reduce ventilation. We were talking about neuronal stimulation and the fact that if we gave someone too much opioids or benzodiazepines, we could actually reduce nerve stimulation coming from the brain and reduce respiratory rate and ventilation. Okay, there's diseases that can cause that too, right? So there's a disease called myasthenia gravis, where it's an autoimmune disease that destroys the acetylcholine receptors of your skeletal muscles, and it also affects the neuromuscular junction of the respiratory muscles. So patients with myasthenia gravis can get into big trouble with inability to ventilate. Okay, and that's the most dangerous part of having or developing myasthenia gravis, is inability to ventilate. How about Guillain-Barré syndrome, which is a disease that destroys and damages the peripheral nerves that are going throughout your body. And in Guillain-Barré syndrome, you can develop paralysis of your skeletal muscles, usually temporary, but also paralysis of your ventilation muscles, your intercostals and your diaphragm. And you can run into significant ventilation issues where you may need to be on a mechanical ventilator. Okay, so those are disease processes. One is a disease of the neuromuscular junction, and that's myasthenia gravis. Guillain-Barré is a demyelinating disease that impacts peripheral nerves, and of course there's peripheral nerves that are stimulating your intercostal muscles and diaphragm. And the biggest concern is that you're going to be unable to ventilate and end up on a ventilator. Okay, so we just had a chat about ventilation on the previous slide. Let's talk about diffusion. Diffusion is the process of what's happening in the alveoli, right? So diffusion always goes down concentration gradients. So oxygen diffusing from the alveoli to the capillary is because there's a higher concentration of oxygen in the alveoli normally. CO2 diffusing from the capillary to the alveoli is because there's more CO2 concentration in the capillaries. Okay? And so diffusion is occurring at the alveolar capillary membrane, right? It's a very thin membrane between the alveoli and the capillary, and that's where it's happening. So what can cause diffusion to be affected? What can make it difficult or impact diffusion between the alveoli and the capillary? Okay, so the first one is pretty unlikely to happen, but when O2 pressures are increased in the alveoli. And under normal conditions, that's not going to happen, right? We typically have 21% oxygen in the blood, in the air, and the pressure doesn't usually increase. Okay. So if we did increase the O2 pressure, say with supplemental oxygen, well, we've now just applied more pressure to the alveoli, and that's going to allow more oxygen, because there's more oxygen concentration in the alveoli. It's going to allow more oxygen to get into the bloodstream and then get onto hemoglobin. So it's going to improve oxygen saturation. If we can improve oxygen delivery to the alveoli with some kind of supplemental oxygen with nasal prongs or a facial mask. Okay. What about the second point? When O2 pressures decrease in the alveoli. So at high elevations, the partial pressure of oxygen in the atmosphere is lower, right? So when you climb a very, very high mountain, there's less oxygen pressure up there. And if there's less oxygen pressure up there, there's less pressure of the oxygen getting to the alveoli. Okay. What about an inadequate oxygen supply? Well, that can also lead to inadequate oxygen concentrations in the alveoli, which then going to cause less diffusion across the alveolar capillary membrane. Okay, so the first two really deal with pressure changes. So basically at higher elevations you have less oxygen pressure, so there'll be less oxygen delivery to your alveoli. Let's look at the third and fourth one. So solubility of gases. So as I mentioned before, CO2 can cross that membrane into the alveoli much more easily and more quickly than oxygen goes into the bloodstream. Okay, and that's why just by breathing faster we can blow off more CO2 and reduce CO2 in the bloodstream. Okay, the next one is a very important one to understand. The distance between the alveoli and the capillary is usually just one cell thick, one or two, right? So what if fluid got between it, such as in pulmonary edema? So there's backup of fluid from the heart because the heart's not pumping properly, and now you have fluid between the alveoli and the capillaries all through your lungs. Well, that's going to make diffusion very difficult. It'll make oxygen difficult to get from the alveoli to the capillaries, and CO2 to diffuse from the capillaries to the alveoli. So, and that's common in congestive heart failure. What about pneumonia, where the alveoli are filled with bacteria, with inflammation? That's going to be a problem with gas exchange in the area of the pneumonia, right? So anything that affects the distance between the alveoli and the capillary membrane is going to impact diffusion. And the most common cause is pulmonary edema, okay? That just puts fluid all through the tissue between the alveoli and the capillary. What about surface area of the lungs? So the lungs have a massive surface area because of these hundreds of millions of alveoli. What if, such as with emphysema, the alveoli are gradually being destroyed? So instead of having hundreds and millions of alveoli, that number is significantly decreased, and you have fewer alveoli, so you have less surface area for oxygen to diffuse to the blood and CO2 to diffuse into the alveoli. Okay, so a damaging disease like emphysema that destroys the alveoli will cause less ability for gases to diffuse. Okay, so I would think of it in these terms. If the alveoli are filled with fluid, such as pneumonia, the gases can't go across very easily. If there's fluid between the alveoli and the capillary because of congestive heart failure, the gases can't diffuse properly. And if there's destruction of many areas of the alveoli, such as in COPD, which is emphysema, there's going to be less surface area for gases to diffuse across. Okay? Okay, so let's talk about perfusion. So perfusion is the process of basically just the blood flowing through the capillaries in any organ. So if we could talk about renal perfusion, we could talk about brain perfusion, cardiac perfusion. In this case, we're talking about perfusion of blood that's going from the right ventricle to the lungs and wrapping around all those capillaries, all those alveoli, and then performing gas exchange there and returning the blood to the left atrium. Okay, so perfusion is just the blood flow, and when we're talking about it in the lungs, it'll be called pulmonary perfusion. Okay, so let's look at different conditions and decide whether it's a ventilation problem, a diffusion problem, or a perfusion problem. So in the top left, the white rectangle represents your airways, the circle represents your alveoli, and the red rectangle represents your capillaries. So if you have anything that's occurring within the alveoli, such as pneumonia, or the distance between the alveoli and the capillary, which is the interstitial fluid that can fill with fluid in the setting of congestive heart failure, which is really the same as saying pulmonary edema. So congestive heart failure causes fluid to back up into the lungs, leading to pulmonary edema. And ARDS, which is acute respiratory distress syndrome, is just another condition in severely ill patients, say for example with after a car accident, where their lungs just fill with tissue around the alveoli. Okay, so these are all issues of diffusion, right? The inability of oxygen to get from the alveoli to the capillaries. Okay, let's go to the next one on the top right. What if you have some kind of scarring disease of the alveoli? And that is typically either a condition such as emphysema, which is destruction of the alveoli, or you can have another disease called pulmonary fibrosis, where basically your alveoli are being destroyed and replaced with fibrotic tissue. So you're losing alveolar surface membrane, surface area. Okay, so whether it's emphysema or pulmonary fibrosis, you're losing alveolar surface area, which is going to reduce diffusion ability. Okay, so both of those are examples of diffusion issues. What about a ventilation issue? Well, asthma, which has can have very tight bronchial tubes, or cystic fibrosis, where you have a lot of secretions in your bronchial tubes. Often you can have infections in your lungs with cystic fibrosis, so they get recurrent pneumonias. They often have thick, tenacious phlegm in their bronchial tubes, and that makes it difficult to ventilate, just to get the air to the alveoli. COPD. So COPD, we'll talk about it in more detail, but part of COPD, which is chronic obstructive pulmonary disease, is increased secretions and damaged airways, damaged bronchial tubes. And that's called chronic bronchitis. So COPD is a combination of emphysema and chronic bronchitis. The emphysema part is the destruction of the alveoli. The chronic bronchitis is the damaged bronchial tubes, typically from cigarette smoking or pollution. Okay, so all of those are examples of ventilation issues. What about a perfusion issue? Nothing to do with the lungs themselves. Well, what about a pulmonary embolus? So typically pulmonary emboli occur because a piece of a DVT has broken off, so a deep vein thrombosis in your leg. So a piece has broken off and traveled up the inferior vena cava to the right ventricle, and then it has been pumped in to your pulmonary arteries, and then become blocked in the pulmonary vessels. That's a pulmonary embolus. That's a perfusion issue, right? There's no blood going to a section of the lung. Okay, and what that means is, even though that lung is receiving oxygen from ventilation, it's not going to receive perfusion to have proper gas exchange. Okay, so a pulmonary embolus is an example of a perfusion issue. Okay, so let's talk about a concept called VQ mismatch. So V is for ventilation and Q is for perfusion in the lungs. Okay, I can't tell you why Q is for perfusion. It was just chosen as the letter. So, and what it means is the parts of the lungs that are being ventilated may not be getting proper blood flow or perfusion, or there may be parts of the lungs that aren't being ventilated, but they're getting normal perfusion. Okay, so it's called a mismatch because typically what should happen is that all the parts of the lungs that are receiving oxygen to their alveoli should also be getting blood flow so that there's proper gas exchange. Okay, so there's a number of things that can happen. What are the outcomes of a VQ mismatch? Okay, there's a term called shunting, and we'll get to that. There's another term called dead space, and there's a term called a silent unit. Okay, so shunting usually means that there's blood flow going to an area, but the area isn't receiving any oxygen. So let me give you an example. When we look at the image on the left, there's perfusion, but there's no oxygen getting to those alveoli. So an example would be tremendous amounts of mucus in the airway of one particular part of the lung. Okay, so say you have COPD with lots of mucus in parts of the airway, in the bronchial tubes, and those alveoli aren't receiving any oxygenation. They're not being ventilated. Okay, so the blood continues on through, but there's really very little gas exchange because the bronchial tubes are blocked in that area. So that would be perfusion without ventilation. And we would call that shunting, meaning the blood going from the right side of the heart to the left side of the heart in that part of the lung is not being actively involved in gas exchange. Let's look at the middle image, and that is what every alveoli should be receiving, where blood comes from the pulmonary artery from the right side of the heart, and it spreads out through all the alveoli, and there's proper gas exchange, and then the pulmonary vein or the venous capillary goes to the right side of the heart with oxygenation. Okay, let's look at the last image. So there's totally normal ventilation throughout the lung and in this particular alveoli, but the blood supply is somehow being blocked. It's not getting to a section of the lung. So let's do an example of no ventilation, but normal blood flow. That's the one on the left. And I mentioned COPD, right? Lots of mucus in the bronchial tubes and resulting in poor ventilation to parts of the lung. And then there's just shunting of blood from the right side to the left side without being oxygenated. Let's do an example of the image on the right, ventilation without perfusion. Well, the classic one is a pulmonary embolus. So a blood clot has traveled and been traveled from the leg to the heart, pumped from the right ventricle into the lung somewhere, and has blocked some part of the pulmonary artery system. And all those alveoli where that blood was supposed to go is now not going to be perfused. Okay, so that could be what's called a VQ mismatch. And the first one on the left, the perfusion without ventilation, is also a VQ mismatch. Okay, so in conditions such as asthma or COPD, you're going to have poor ventilation, but you're going to have still the perfusion coming through. In the image on the right, with a pulmonary embolus, you're going to have normal ventilation, but no blood supply going to that area. Okay, so that's the concept of VQ mismatch in different diseases. So shunting is really the one on the left, perfusion without ventilation. What's dead space? Well, every time you take a breath, there's the last part of your breath that goes in stays in the trachea and the bronchial tubes. They never see the alveoli. And then you breathe it out, right? So that's called your anatomical dead space, meaning the air that you brought into your lungs, there's a part of it that never sees gas exchange. And as the end of inspiration, that air stays in your bronchial tubes and your trachea and then gets breathed out again. And that happens with every breath. Okay? So we all have anatomical dead space that's built in to every breath because we all have trachea and we all have bronchial tubes. What's a silent unit? Well, a silent unit is really an area of the lung that's not being ventilated. So let's say there's a lung cancer that's blocking up a whole portion of bronchial tubes to a part of the right lung. Okay, there's no ventilation going to that section of the lung. And finally what happens is the blood supply stops going there because there's no oxygen, and the blood supply senses that and reduces the perfusion to that area. So it's a completely inactive area. It's silent. Okay? So just understand the concept of what VQ mismatch is. Ventilation versus perfusion. They should be very equal, that you can see in the middle image. And when they become unequal, such as the image on the left or the image of the right, we call it a VQ mismatch. And VQ mismatch can come from inadequate ventilation. That's usually something wrong with the lung, such as COPD or asthma. And a VQ mismatch can also come from lack of perfusion, and that's the image on the right. Okay, so I hope that's not too confusing. If it is confusing, bring it up in the tutorials so we can go over it. So let's talk about some conditions that are caused by inadequate ventilation or diffusion or perfusion. Okay, so what about hypoxemia? So hypoxemia means reduced oxygen levels in the bloodstream, in the arterial blood, your PaO2. It's not telling you how much of your hemoglobin has oxygen molecules on it. That's your O2 saturation. Okay, so hypoxemia can result from hypoventilation. So someone who's breathing very slow and very shallow because they received too much benzodiazepines or too much opioids, or they overdosed on opioids. Okay, that's going to result in hypoxemia. What about diffusion abnormalities? So there's backup of fluid from the heart in congestive heart failure, and that has made the tissue full of fluid between the alveoli and the capillaries, and now oxygen can't get across. You're going to become hypoxemic. What about decreased pulmonary perfusion, such as a pulmonary embolus? So you have oxygen going to all the alveoli, but there's blood that's now blocked from going to a part of the lung. So what's going to happen is the blood supply is going to go to other parts of the lung, but it's never going to see the oxygen from the portion that's blocked. Okay, so that's going to result in hypoxemia because all the blood has to go elsewhere because the pulmonary embolus has blocked a portion of the lung, and it's still being oxygenated, but it's never going to get into the bloodstream because there's no blood flow there, and the patient will become hypoxemic. So you can become hypoxemic from a pulmonary embolus. Okay? Hypoxia is the term used for reduced oxygenation at the cellular level. So if I have a blood clot in my left artery of my leg, the cells all down my leg are going to be hypoxic. They're going to have reduced oxygen getting to them. Okay, so hypoxia is really used for a term where the cells of the organs aren't seeing the proper amount of oxygen. They're ischemic. Ischemic means lack of oxygen to an area. Okay, so if you have hypoxia in a part of your brain because you have a blocked artery called ischemic stroke, those cells, those brain cells are going to become hypoxic. What about hypercapnia? So elevated CO2 in the arterial blood, and that's your PaCO2. So if you're breathing really slowly, again because of opioids or benzodiazepines, you're not clearing the CO2 that's being breathed out properly because you're not ventilating properly, and the CO2 is going to build up in your bloodstream, and you're going to become hypercapnic. A patient, say, with severe COPD, and they have such injury to their alveoli, scarring and fibrosis and damage to their alveoli from emphysema. Well, when they have a COPD flare-up with even more mucus in their airways, and they're not able to ventilate properly, they can't clear their CO2, and the CO2 rises in the blood, and COPDers can become hypercapnic. And when you build up CO2 in your bloodstream, the CO2 combines with water and becomes H plus and HCO3. And H plus is acid, and that's why they result in a respiratory acidosis. So whenever a respiratory condition results in elevated CO2 levels in the bloodstream, we call that respiratory acidosis. Okay?